Just listen, right? Just listen, because I'm not a radiologist. I'm just going through some X-ray, right? And sorry? Right, no problem. So I'll show you some X-rays, and after that, when you see a X-ray, just try to describe the X-ray. The way that I'm going through these X-rays. Okay. Right, these are normal looking X-rays, right? So, although we call X-rays, these are radiographs, right? X-ray means X-ray beam, and so we normally call chest X-ray. And chest X-rays, all the doctors should be able to read chest X-rays, right? Because in the OPD and all, when you post-intern, you are supposed to sign for medicals. At least you should be able to say whether it is normal or abnormal, you have to say, right? So you are supposed to sign for medicals. So any doctor should be able to read chest X-rays. And then we have X-ray. Normally we do PA X-rays, posterior anterior beam. The reason is your heart is anteriorly placed. So when you do PA film, you keep the patient like this in this position and get the patient to keep the hands away like this over. And then the scapulae won't overlap the shadows. Right? When you keep here, your X-ray source is kept 72 inches away and it is coming like this. So it's a divergent beam, right? So if you keep the patient on the other way, your heart shadow will get some apparent enlargement, right? To prevent that, we do PA film, right? So normally we do PA film. In addition to PA films, we do a lateral film because there are certain areas, for example, say there's a mass lesion somewhere here, might not be shown as seen in the PA film, right? There are areas which you can't see on a PA film. And sometimes the patient can come with pleuritic type chest pain, fever, suggesting a small pleural effusion. Might not be sure as to the PA film. So because the pleural effusion maybe they are in the posterior postophrenic angle, right? So you are supposed to do a lateral film also, ideally, but not always. We don't do these lateral films, right? Then chest X-ray is a basic test, and you are supposed to do chest X-rays in a lot of conditions, right? Even with a single episode of mild hemoptysis, there is an indication for a chest X-ray, right? That may show the earliest the features of TB or malignancy, right? So there are a lot of indications: persistent cough, then loss of weight, loss of appetite, shortness of breath. So there are a lot of indications, even persistent fever, a lot of indications for chest X-ray, right? Then whenever you want to do a X-ray in some other site, for example, joint X-ray, knee joint, there is a patient with knee joint swelling, and you are doing X-ray there is always indication for a chest X-ray. Say there is a patient with headache and you are doing a skull X-ray or CT scan, brain, there is indication for a chest because the primary pathology may be there in the chest. Okay, say for example, if the patient is having backache and primary pathology may be there in the lungs, primary malignancy or TB may be there in the lungs, right? So there is always there is indication for a chest X-ray if you are going to do a X-ray on some other site, right? Don't do other X-rays without doing a chest X-ray. Because we have seen examples, right? Some people do CT brain, MRI, everything, and finally you see a lung cancer in the chest X-ray several weeks later, right? Then there are other X-rays that we can do. So this is a PA, this is the lateral. So if you have a lesion on the right side, we ask for a right lateral, right? The lesion is the left side, we ask for a left lateral, right? Then there are other X-rays, right? So if your lung apices are not clear, you can ask for an apical view. Then we will do some, X-ray beams going like this. So then the scapulae, this clavicles will come up, and you can see the lung apices clearly in apical view. Then sometimes if you suspect fractures here, you can ask for an oblique field. So in oblique fields, you can see the fractures clearly, right? And then say if there is a pneumonia here and you are suspecting a pleural effusion there, you can ask for a lateral decubitus film, like in this position. You keep the patient in the lateral decubitus position and do a X-ray, right? Then you can see the free flowing of the fluid. So you can measure the height of the fluid also. If it is more than 1 centimeter, you can aspirate. If it is less than that, if you try to aspirate, you might cause pneumothorax and also you can measure the height of the pleural effusion also. And normally the pneumonic patients who are having less than 1 centimeter height pleural effusions are going to respond to your antibiotics. Still, if you want, you can aspirate a guided aspiration and all, right? Right, so those are the type of X-rays. Then, before reading, even in the surgery, say if there is a patient with road traffic accident having long bone fracture, you are supposed to do a chest X-ray. Otherwise, you will miss the pneumothorax part, okay? And you will give the anesthesia, the patient will die on the table because of the pneumothorax, right? Then, before reading any X-ray, hello. ඉතින් පොඩ්ඩක් ෆෝල් කරලා ඒක මොකෙනිට කියන්නේ පොඩ්ඩක් අපි respiratory surgeon මේකට සයිකල් දෙන්න බලන්න එනවා ඉතින් මේක කියන්නේ taking what right. So before reading any X-ray, the identification is important, and say name, age, everything. Sometimes the DHT and the date is important, and identification is very important because you might take decisions by looking at all the X-rays, right? And then even if the X-ray is normal, you get the patient to preserve these X-rays, keep them these X-rays, right? Later on, they are going to help you, right? So we have a lot of TB patients. At the end of the treatment, we do a chest X-ray and ask them to keep. So the next time when they come with symptoms, to look for reactivation or to look for some other pathology arising there, you have to have the previous X-ray. You have to keep those two and compare. So all the X-rays are very important. Ask them to keep. Right? So identification is important. Even if the name, everything is there, just look at the patient and look at the X-ray and see whether this particular X-ray belongs to that particular patient. You have to think of. But sometimes a lot of mistakes can happen in the chest X-ray department if there are same names and all, right? So you have to look for that also, right? And there is no excuse if you put an IC to some other patient, right? By looking at some other X-ray, right? Doing various invasive procedures, right? So you have to be clear, and so the identification is very important there. And always look at the breast shadows also when you read the X-rays, because roughly you can say female or male. And other thing is in the exam, these are common cases in the exam. You might get pleural effusion patient with absent breast shadow, mass lesion with absent breast shadow. Then you should know that the patient is having a CA breast who has undergone mastectomy and coming with secondaries, right? So if you don't look at that one, you will miss that part, so you will miss the part of your diagnosis, right? Okay. So after looking at dates and everything, there are three things that you have to look for before reading the X-ray. Don't go and try to read the X-ray without checking all these things, right? One is whether it has been done at the correct position. So if you keep the patient correctly like this, these spinous processes which are here should be in between the clavicles, right? Clavicle head. So it's a well-centered fit, right? So if it is rotated, your one lung will be darker than the other one hilum will be prominent. So you might think of hilum abscess and all. Here we have seen enough cases like this, people saying suspecting hilum and all. The only problem is the rotated film, right? Then these chest X-rays are done during deep inspiration. If the patient has not taken a deep inspiration, you should be able to count more than 5 ribs anteriorly in this position, right? 1, 2, 3, 4, 5, 6. He's touching here, so he has taken a deep breath, right? Supposing this diaphragm is somewhere here at the level of the 4th rib anteriorly, then everything will be like this. So you will see bilateral opacities and all because of the congested vessels. So ideally the patient is not having any inflammatory change, but you are thinking of inflammatory shadows because of underexposure. And the cardiac contour might get altered, so you might think of cardiomegaly also, right? So X-rays should be done in deep inspiration. Other thing is the X-ray exposure, right? Just remember like this, your intervertebral discs should be barely visible through the cardiac shadow if the exposure is good. Intervertebral disc should be barely visible through the cardiac shadow. If you can see whole spine, then that is overexposed, so everything will be dark. And then easily you can miss pneumothorax. And if you can't see intervertebral disc through the cardiac shadow, everything will be whitish, and all these whitish areas may be due to soft tissue shadows there and may not be having any inflammatory shadows. Okay, so exposure is important. So look for everything before reading the X-ray, right? Then when you want to read the X-ray, you have to have some order. So we are interested about the lungs. So we start here, the trachea, then the right main bronchus, and in the left main bronchus, right? And then we know that this is a upper zone, mid zones, lower zones, right? The lungs. And then we look at the hilar vessels, right? And these are all vessels. People talk about bronchovascular markings, but these are vascular markings. Sometimes in bronchiectasis and bronchopneumonia or some other conditions which refers to bronchial thickening, then you will see the bronchial markings also in bronchiectatic patients. Otherwise, this is what you see here. These are vascular markings. Then look at the size of these vessels compared with the cardiac shadows. These are dilated. Think of pulmonary hypertension. Okay, and the distribution of the vessels. If the normally the lower lobe vessels are bigger than the upper lobe vessels, right? If you see bigger upper lobe vessels, you think of upward diversion. That happens in cardiac failure, right? Okay, then so you have to have some order. You look at the vessels and then the cardiac contour you see, and then if you are interested, you can look at the abdomen, right? Look for various calcification and all, and the soft tissues, and then the bony case. So you have to have some order to look at the chest X-ray. That order should be fixed for the rest of your lifetime. So if you just go and see here and there, you might miss certain things, right? If you don't clearly look for these bony case, look at these vertebrae and all, clearly you might miss, right? So you have to have an order to look at X-rays. The other thing is, there are various terms used by radiologists, right? Homogeneous opacities, ill-defined opacities, well-defined opacities, then cavitative lesions, consolidations, miliary shadows, nodule opacity, like that. The radiologists, they use various terms, and some of these terms have a meaning. If you say a consolidation, there should be an opacity with the air bronchopneumonia. So I go through the other X-rays. I have enough examples. And if they say abscess, there is a cavity with the fluid level. And if they say cavity without any the fluid level. So abscess means cavity with the fluid level. If they say miliary, 2 mm widespread shadows, all less than that. So that is miliary. If they say honeycombing, there is honeycombing appearance. So there is a definite description is there. So use these terms to describe X-rays, right? Then to read chest X-rays, you should be able to describe the normal appearance of a chest X-ray, right? If you know the normal chest X-ray, then you can describe the abnormalities, right? So we have to concentrate on normal appearance of that particular patient, right? So if I start from here, this is the trachea, and next to the trachea you get only few millimeters of soft tissue, right? If there is big margin like this, you think of paratracheal opacity masses and all. So we have enough patients like that, right? Then these are hilar vessels. Hilar vessels, the left hilum is slightly higher level than the right one. And then some patients you can see the transverse fissure. Transverse fissure touches the sixth rib laterally. I will show you some example. 1, 2, 3, 4, 5, 6. It should be somewhere here, right? Then there are nice lines, right? This is the ascending aorta, and this is the right atrium, and this is the right hemidiaphragm. And for you to get these nice lines, there should be a soft tissue margin. Above that, there should be air, or next to that, there should be air. That is how you get this nice line, right? For example, next to the right atrium, you get the air in the right. What is the lobe there? Middle lobe, right? If there is opacity in the middle lobe, this line will disappear, right? If there is opacity in the lower lobe, this line will be intact and there is opacity there, right? So this is how you find. I will show you some examples. Yeah? And then this line is left ventricle, and always concentrate this part of the hemidiaphragm, right? So a lot of people miss lesions behind the heart. If you don't look for behind the heart lesions, you are going to miss. Okay? And this is the descending aorta, which is posteriorly placed, and this is the descending that you have to look for that, right? So these are digital films. Digital films, you know, the exposure they can, you know, when they want to print, they can make some alterations and then they print. So I'm not going to talk about this, these, right? These are digital films, and you can see nicely hemidiaphragm behind the heart. So heart is anterior place, so this represents the hemidiaphragm behind the heart. Supposing if there is a mass or something touching here, this line will disappear, right? If there is a mass or something touching the descending aorta, this line will disappear. So these are the points that a lot of doctors won't look at. So make it a habit to look at them, right? And then the, you know, this is the left ventricle. Next to that there is air in the lingular lobe. So if the lingular lobe is involved, this line will disappear. So if there is a opacity here and intact left ventricular margin, that means that fellow's lingular lobe is intact and there is opacity behind the heart, that is in the lower lobe, right? So this is how you assess. And then this part of the area, this area is called aortopulmonary window. And the patients who have got hoarseness of voice always look at this point, because the recurrent laryngeal nerve left side comes around this aortic arch, right? So lesions here will catch that. So aortopulmonary window you have to look for, right? So that is about normal appearance. And then the cardiac shadow. Cardiac shadow, the 1/3 of your cardiac shadow should be on your right side, 2/3 on your left side. Sometimes in normal people, the cardiac shadow might get, you know, shifted to the other side. So you then palpate here and see whether the patient is having pectus excavatum, right? When there is a thoracic called the pectus excavatum, the cardiac shadow might get shifted to the other side. So it's a normal variation, right? So if you know the normal appearance, normal pattern of the X-ray, then you can detect the abnormalities, right? Then when it comes to the lateral film, now the lateral film you can see two thoracic cages, right? Here you can see two thoracic. Have you noticed these things in the X-rays, right? So these are two thoracic cages. So what happens there is, now we have done a right lateral, this is also right. So when you do right lateral, you keep the right side of the chest over to the X-ray plate, and your beam is coming from this end. So it is going like this. It's a divergent beam. So left side get displaced out. If you do a left lateral, the right side will get displaced out. So then in a right lateral, let's say this is the right and this is the outer one is the left. Then you can identify the hemidiaphragms, right? So starting from right, it is the right hemidiaphragm going up to the right side, nothing above the hemidiaphragm, there is nothing above. So you can trace from this end to this end. the left side you can't, the anterior you have the heart, so left side, the anterior 1/3, so you may not be able to see some lot of x-rays, right? So this is the left, starting from here, it's the left hemidiaphragm. So if there's a pleural effusion in the left side, you will see something like this. The right side it is shown like this, right? And another point that you have to remember is there is a darkness above the heart, and that darkness is equal to the darkness behind the heart. So that also you have to notice, right? Always do look for these bones and everything, whether there are collapse vertebrae and all, you have to look for. But I'm talking about the lungs here. And if this has disappeared and this darkness is there, you will see something in the anterior segments of upper lobe or mediastinum, right? If this darkness is there, everything whitish here, something wrong in the basal, left or right, right? So these are the normal appearance of a chest X-ray. Then I will go through various abnormalities there. So just remember the normal appearance. These are some pleural effusions, but not typical pleural effusions. So you have enough typical pleural effusions in the wall, right? All these patients have pleural effusions, right? Starting with this one, so you can see this is probably female patient, and this is the sinus process, which is close to the left clavicle, so it is a rotator field. And you can see whole spine there, and not only the intervertebral discs, right? So I told you, if it is good exposure, intervertebral discs should be barely visible through the cardiac shadow. So you can see whole spine. So this is overexposed field, lot of X-rays here. So that is why the everything dark here, right? So if there is a small pneumothorax here, you are going to miss that, right? Then, so this patient has a opacity, so homogeneous opacity, which is laterally placed, and in addition to that, some opacity is there. So this is a laterally encysted pleural effusion. So the pleural effusion is going around and it is encysted there, right? And you can see the diaphragm also here. Otherwise, the normal, simple pleural effusion will see something like this, with a concavity line moving up, right? So it's a lateral encysted pleural effusion. Right. This one again, it's a grossly rotated field, and you can see whole spine. So this is overexposed, right? But both patients have taken good break. So this is done in inspiration, right? And here also you can't see the right hemidiaphragm, but here you can see, depending on where you can see, right hemidiaphragm you can't see above, because above that there is fluid. So this is a concavity moving up. So there is fluid in the right side, right? Side-sided diffusion. And in addition to that, there is fluids here also. If you count 1, 2, 3, 4, 5, 6, it should be here, but this is the transverse fissure, fluid in the transverse fissure, but it was moved because of the right side losum pleural effusion. Now in this X-ray, fairly well centered, little bit rotated, you can't see the intervertebral disc there. So this is underexposed field. Underexposed field, and right hemidiaphragm you can't see. Again there is a concavity like this here. So there is a right-sided pleural effusion. In addition to that, you can see fluid lying there, and there is a rounded opacity, right? If you count 1, 2, 3, 4, 5, 6, it is here. So this is a fluid in the transverse fissure. And this rounded opacity is not a tumor. What happens with pleural effusion is sometimes these fluids get collected in the oblique fissure or transverse fissure. So it is called a pseudotumor. It's not a tumor. It's not a tumor actually, right? And in addition to that, you can see some blunting of the left costophrenic angle. Now you see this costophrenic angle is nicely sharp, right? Here it is blunting. So this patient may be having bilateral pleural effusion, right more than the left side, underexposed field, but patient taken a deep breath, slightly rotated, right? And transverse fissure also there is fluid, so you can see a lot of things, right? In addition to that, you can say, compared to these patients, this may be a little bit thinly built patient, right? So here you have a fluid line. If you see a line, straight line there, always there should be air above it. Normal pleural effusion, it will be like this, concavity moving round, right? So if you see a line there, always think of above that the air, that is hydrothorax, right? So this patient is a TB patient. He has left side a lot of cystic changes, inflammatory shadows, acute TB changes with right sided hydrothorax. This is the collapse lung. In addition to that, so this is IC2. You can see small line of air outside the chest wall, so that is surgical emphysema, right? Okay. This is also pure quality X-ray. I don't have the PAB here, but I am keeping this separate. A lot of signs are there, right? So I told you this darkness should be equal to this darkness, so there is no darkness here. And this is a right lateral X-ray. So right lateral X-ray, inner one is the right, outer one is the left thoracic cage. So then starting from left side, it is the left hemidiaphragm, right? Left hemidiaphragm, and anterior answered in the left side you can't see because of the cardiac shadows out there, right? And then this should be the right hemidiaphragm. So then this should be the right side oblique fissure, fluid in the oblique fissure. So what has happened to the posterior part of the right? Because right hemidiaphragm you should be able to see from here to there, but this part you can't see because this part of the line is missing because there is encysted fluid posteriorly. Okay, fluid encysted posteriorly. So because of that, this line you can't see. For you to get a line, there should be a soft tissue margin. Next to that, there should be air. So there is encysted fluid. Okay. Right. So it is obvious these are some mass lesions, right? These are digital X-rays and well centered, taken at the right? So there is a left side. If you see this is the descending aorta, this is the left hemidiaphragm. You can see everything left side, right? But right side there is a mass here, okay, with a well demarcated mass, right? What you have to notice here is, now even though there is a mass here, through that mass you can see the vessels, right? So vessel margin is intact. That means this mass is not touching the vessel margin. Okay? So these vessels should be either posterior or anterior to the mass, right? Then look at here, this is the right atrium, and the ascending aorta margin you can't see. So this mass is touching the ascending aorta, so that is why you can't see. So this mass should be anterior to the vessels in the anterior mediastinum. So this is how you say anterior mediastinal mass by looking at a PA. So if you see the lateral X-ray, same patient, you can see darkness here, and this darkness has disappeared. So this mass is somewhere here. Okay, and this one is a very centered film, digital film, must be female patient, right? Again there is a mass here, right? Through that mass you can see the vessels. So that mass is not merging with the vessels, either posterior or anterior. Then look at the cardiac wall. So up to this level you can see the left ventricle. Beyond that, all merging with the mass. So this mass is next to the left ventricle, touching the left ventricle upper side, right? So it is anteriorly placed mass. So you can see the vessels. So vessels are behind the mass, right? Okay. Prednisolone දීලාද බලන්න යාට. prednisolone නැත්නම් උදේ ඩෝස් එකම දාලා ඉන්න. Here again you can see a nice mass here, right? And you can see the vessels also. So vessel margin is not touching this mass. So these vessels are not within the mass. Okay, and then you can see the ascending aorta. So it is not at the level of ascending aorta, not at the level of vessels. It should be posterior. So this is a posterior phase mass lesion. So this is a lateral X-ray, anterior is okay, right? And this mass is here. Okay. So by looking at PA, you have to say this is a posterior phase mass lesion. Okay. When you see a line like this, always you have to think of hydrothorax, right? So line is there, and this area is the more lung tissues, and here you can see lung tissues up to here, and no lung tissues here. So this is a pneumothorax with some adhesions laterally. Okay, so this is a pneumothorax with some adhesions laterally, right? They come with good chest pain, shortness of breath. If you look, you have to look for pneumothorax. Certain pneumothorax you can't see. If you don't look for, you are going to miss. For example, this patient. Now there is a small pneumothorax here. You can easily miss. So if you don't look for pneumothorax, this looks like a normal X-ray, right? So chest pain patients, you have to look for pneumothorax, right? So this is the margin. So this is a small pneumothorax. And if you miss and send the patient home and get something on the way, and patient is going to die, so then you will be caught because you have done the X-ray and you have not seen, you have not detected. So it's like negligence. Okay, so don't miss pneumothorax. You have to look for pneumothorax, otherwise you are going to miss. Right? This will be very easily. This can be missed. Now this patient. Everything looks whitish, intervertebral disc you can't see. 1, 2, 3, 4 is touching here, right? Looks expiratory. And patient has bilateral reticular nodulopathy. So it's a patient with primarily fibrosis. And if you look at here, no lung tissues this area, suggesting there's a small pneumothorax there. So this is a lung fibrosis patient presenting with pneumothorax, right? And why this is expiratory? Because of the fibrosis, he can't take a deep breath, right? He has restrictive lung disease because of severe fibrosis. He can't take a deep breath. So this is what he can take. Whereas this X-ray, right? This one you can see, this is a rotated film, thinly built patient, right? And you can see whole spine there, so everything is dark. So this is overexposed film. And it is overexposed. There is something like this and no lung tissues there. So this is a big emphysematous bullous lesion. And your cardiac shadow, 1/3 should be here and it has shifted there. So it's a big right-sided emphysematous bullous lesion, right? Why I call bullous is this is going round like this, and this is coming like this. Sometimes you find it difficult to differentiate emphysematous bullous lesion from encysted pneumothorax. But in pneumothorax, you will see something like this, going like this, right? Encysted pneumothorax, but it is difficult sometimes. But it is very important to differentiate, because if somebody thinks of pneumothorax here and put IC tube, this patient is going to die, right? You get a severe bronchopleural fistula and he is going to die, right? Whereas if it's a big pneumothorax, if you don't put IC tube, he is also going to die, right? Sometimes you may have to do CT to differentiate, right? So this shows some cavities, right? So it's a digital film, well centered, right? So it's a big thick wall cavity. So you can do a lateral and see. So they have done a right lateral here. So this is the right pneumothorax, right? So this is the left one. Starting from right, it is the right hemidiaphragm. And starting from there, this is the oblique fissure. You can see the oblique fissure. And this is the left hemidiaphragm. Anterior one third you can't see because left side heart is there. So this is a thick wall cavity. If you look at the position, this is in the apical segment of lower lobe. So it's a common site for TB. Apical segment of lower lobe is a very common site for TB, right? So if it is TB, this patient, the sputum should be positive, because if there is a cavity, there should be a lot of AB, so AB should be positive, right? Then this X-ray, 76 years, right? And a lot of radiological changes are there. Obvious thing is this: there is a cavity with irregular inner margin, thick wall cavity with irregular inner margin. Always think of malignancy, right? Cavitating malignancy, especially the squamous cells here. And then look for other features. So this is the rib, and this part of the rib is missing, right? So this is a rib erosion next to that cavitating lesion, right? So it's a feature of malignancy, right? Inside there, nodular appearance is there, right? But there are a lot of other changes. Hello. Bala nae ne. Hari. Ena kaman. Hari. There are a lot of other changes, right? Now I told you cardiac shadow should be here, 1/3, but it is shifted there. And if you look at the right lung and the left lung, there is volume impairment in the left lung, right? That you have to notice. So then if you look at here and here, very little lung markings here, suggesting emphysematous area in the right side. So emphysema is in patients with smokers, right? See, heavy smokers will have emphysematous changes, and heavy smokers can come with squamous cell CA, right? So there is volume impairment in the left side that indicating some kind of collapse there. In addition to that, these ribs, compared to these ribs, the left side rib crowding is there, right? Even the left hemidiaphragm is now coming up, right? So why I told you these things is, these are features of underlying lung collapse. Okay, the cardiac shadow, mediastinal shifting this way. Sometimes you can have the tracheal deviation to the left side, so there is small tracheal deviation, and there is crowding, elevation of hemidiaphragm, volume impairment, right? All are additional features of some underlying lung collapse. So there may be collapse due to malignancy here, the left upper lobe, right? So rib crowding, volume impairment, tracheal deviation, the mediastinal shifting, elevation of the hemidiaphragm, all are suggestive of some collapse underlying. Okay, right. Some of the quality X-rays, right? Right. So this is what is called miliary, so 2 mm less than that widespread opacity, right? This X-ray is well centered, but you can't see the intervertebral this through the cardiac shadow. So this is underexposed field, right? And maybe obese female patient, you can see the thick chest wall, so with miliary motility, right? Here again you can't see the intervertebral. This underexposed, very thick chest wall, obese patient having nodular opacities, and you can't see the descending aorta, you can't see the left hemidiaphragm. So there must be something behind the heart above the left hemidiaphragm, maybe behind that, maybe a pleural effusion or mass lesion, right? In addition to that, there are nodular opacities. This one has bilateral, ill-defined, rounded or patchy opacities, mainly distributed mid and low zone. This is very suggestive of malignant secondaries. But you have to consider all the other possibilities like TB, bronchopneumonia, vasculitis, everything you have to think of. But this is very suggestive of a malignancy and very thick wall, thick chest wall, obese patient. So you have to palpate and see whether there are other evidence of malignancies, right? So if you see this, it is easy. So it's a miliary mottling. Miliary mottling, there are causes. One is miliary TB, miliary malignancy, then extrinsic allergic vasculitis, sarcoidosis. So there are few causes for miliary mottling. So if you see this, you have to think of those possibilities, right? This is again lung malignancy with intrapulmonary secondaries. Here also you can see crowding, elevation of hemidiaphragm, shifting of the cardiac shadow, volume in camel left side, right? Poor quality X-ray. This is also very bad. This patient also is a patient with miliary TB. You can see miliary mottling. And it's a digital film, well centered, taken a deep breath. And this is the left costophrenic angle. So what about the right side? There is blunting in the right side. So there is a small pleural effusion here. In addition to miliary mottling, there is a small right-sided pleural effusion, and there is fluid in the transverse fissure. If you count 1, 2, 3, 4, 5, 6, it is touching the same. So it's a transverse fissure is in the correct position, right? So cardiac shadow is little bit rotated here, shifted here. You have to palpate here and see whether there is pectus excavator. Basically, I have most of the lung pathologies, so go and read everything, right? So if you look at here, this one, it's a well-centered film, but you can't see the intervertebral disc, so it is underexposed. And you can see this thick chest wall, so it's an obese, must be female obese patient. And then look at this diaphragm. So the left hemidiaphragm you can see nicely. Although this looks odd, you can see a lot of things here, right? Poor quality X-ray, you can see them. So this is the left hemidiaphragm, and right hemidiaphragm is elevated, right? More than 2.5 centimeters away. So it is elevated right hemidiaphragm, right? So if you see a heavy elevated right hemidiaphragm, you have to think of two things. One is diaphragmatic palsy, other one is subpulmonic pleural collection, right? Subpulmonic pleural effusion or diaphragmatic palsy. So this is a patient with diaphragmatic paralysis. So you can do ultrasound fluoroscopy and see the movements of the hemidiaphragm there, right? If it is paralyzed, there will be paradoxical movements. So during inspiration, your diaphragm goes down, right, and with the contraction. But here what happens, it will go up when you try to inspirate. So all paradoxical movements. So this is a paralyzed hemidiaphragm. When there is a paralyzed hemidiaphragm, you can see some atelectasis low zone. Sometimes you can get basal pneumonia also, right? This patient here with hemoptysis, and you can see rounded opacity here, and surrounding that opacity you can a halo mark, right? So this is a feature of cavity with the intercavitary bodies, right? Now this X-ray is a little bit rotated, you can't see the intervertebral disc here, so this is the underexposed field. So all these whitishness here due to underexposure, not exposed properly, right? There is nothing wrong here and there, and it's a thick chest wall. So what happens here is, now we give the same dose of radiation to get the X-ray. When the patient is very big made with thick chest wall and all, that becomes underexposed. So the radiation is not enough, right? X-ray is not enough. So to confirm that, you can see, you can do a lateral decubitus here. Then this dark area will come up here. This will fall down. So these are actually cavity with the intracavitary body, or common thing is the mystroma, and inside cavity sometimes you can get masses, mass malignancy. Inside cavity you can get blood clots. Inside cavity you can get thick pus sometimes. Okay? So So this is, you can see this patient's chest wall. This is a wasted patient, right? Wasted patient. You can see the most of the spine also there, right? So there is a cavity, big cavity, and this must be the transverse fissure. The cavity with the fluid level. So cavity with the fluid level means there's a lung abscess. So it's a lung abscess. So you can do a lateral and see. So in this lateral X-ray, you can see the oblique fissure, some bulging here, and the transverse fissure right side. So middle lobe is intact, lower lobe is intact. This cavitating lesion, that is this lung abscess is in the right upper lobe, apico-posterior area, not in the anterior area, right? So it's a nice lung abscess, right upper lobe. So these abscesses always you have to exclude TB. You can have tuberculosis abscess like this and treat with antibiotics. So when you treat, you have to give anaerobic compound like indamycin, in addition to other antibiotics. And you are supposed to continue antibiotics if it is pyogenic one after 6 weeks, right? If it's a single abscess in only one side, you have to do bronchoscopy and see whether there is proximal obstruction, right? So these are, you can see these are ICU. Both patients, two different patients, ICU. Now two different patients from the ICU, right? Don't look at this one, we'll see this one later. Right. If you look at this X-ray, now you can ICU, you can't do PA films. You are supposed to do AP films. When you do AP films, the patient is keeping the hands like this. So you will see overlapping of scapula there. So it's a AP film. And then must be a obese patient, right? Deep chest wall. Then you can see whole spine. Although it looks whitish, you can see whole spine. So this is overexposed field, right? So that is why this area is the normal lung tissue, which is dark. Okay. So this is an overexposed field, well-centered AP field. Okay. And what you see here, now I can't see the cardiac shadow here, it has shifted there. I can't see the descending aorta, I can't see the left hemidiaphragm, I can't demonstrate the normal anatomy there. So look for the normal anatomy. I can't see the left, like in this case, I can't see the left heart border, right? So normal anatomy is this. There is a whitish area with some branching air within that. So this is called air bronchogram. So this is opacity with air bronchogram means consolidation. So ICU patient, we have put the patient to ICU because bilateral pneumonia, bilateral consolidation. And even if you see here, you can see opacity, some branching air bronchogram is there. So these are consolidation. So it's a consolidation, right? So these are bilateral consolidations with air bronchogram. In addition to that, this area is homogeneous. Opacity is there, whitish area there. Probably he is having pleural effusion there. You have to do ultrasound and see. And the heart shadow is shifted here. Maybe the left lobe is collapsing now. We don't know. Hello. අරේ වණිපා කොයි එකද ඔය කියන්නේ DB එක ඒක හදිසි නෑ යවන්න පුළුවන් නම් යවන්න නැත්නම් කැෂුවල්ටි නෙවෙයි ක්ලිනික් එකට යවන්න. එයා සයිකියාට්‍රික් පේෂන්ට් කෙනෙක් නෙමෙයිනේ. ක්ලිනික් එකට යවන්න ඉතින් මම ලියලා තියෙන්නේ මෙයාගේ. එයාගේ ක්ලිනික් එකට දවසට යවන්න. ක්ලිනික් එකට. යවන්න තමයි. Right. These 6 different patients, right? And again you can see whole spine overexposed, everything dark, right? This X-ray also you can see opacity here with branching air. So this is opacity with air bronchogram, that is consolidation, right? The left side you can see the left heart border, not like here. So there is air in the left lingular lobe. Lingular lobe, upper lobe may be intact in this patient. And again behind the heart you can see air bronchogram. So again this patient has bilateral consolidations, right? ICU patient. This one is a young one who came with left-sided chest pain and fever, suggestive of pneumonia. So this X-ray, so I ask you to look for descending aorta and the hemidiaphragm here. Hemidiaphragm you can see, but I can't see the descending aorta here. That is because next to the descending aorta there is opacity behind the heart, and you can see this left ventricular margin nicely. So nothing has happened to the left lingular lobe. Everything should be behind the heart in the lower lobe. So when I listen posteriorly, there was a bronchial breathing here. So it's a consolidation behind the heart, and I heard a nice bronchial breathing behind here. Okay, so you can see opacity, you can see branching air here, right? So opacity with the air bronchograph, so it's a consolidation, right? So this is a lateral X-ray. The lateral X-ray is the left lateral one. So inner one is the left, outer one is the right. Starting from right, it is the right hemidiaphragm going like this. So this must be the left hemidiaphragm. But posterior part of the left hemidiaphragm you can't see. The reason is above there is that consolidation. So no air touching the left posterior part of the left hemidiaphragm. So because of that you can't see this line disappears here, and this is the consolidation. Okay. So if you look at this X-ray, it's normal looking X-ray, but if you look carefully you can see a lot of things. What you have to concentrate is the normal findings, the descending aorta. If you don't look for descending aorta, you are going to miss this. Here is again digital film, rotated digital film. Obvious thing is you have opacity here with a cavity. Okay, and what has happened to the right heart border you can see, descending aorta also you can see. Left heart border is not clear. So this opacity should be touching the left heart border, so it should be in the lingular lobe. Okay, and there is a mass-like lesion obstructing the aortopulmonary window. So there is a mass in the aortopulmonary window, and then there is a cavitating lesion in the lingular lobe. So this is the lateral X-ray, left lateral, right? Left lateral. So this must be the left coming here. Starting from there, it's the oblique fissure. So nothing has happened to the left lower lobe. And this is the lingular lobe, which is next to the heart, and there is a cavity. So you can see everything there. And the left lower lobe is intact, and this is the right hemidiaphragm. So you can see that if you carefully look at this X-ray and you know the anatomy, you can describe these things. Okay. So what has happened here is, now we did bronchoscopy and looked at the lingular lobe entrance, and there was a mass blocking the lingular lobe. Okay, causing distal pneumonia. So it's a secondary cavitating pneumonia due to this mass lesion obstructing the lingular lobe bronchus. So here you can see whole spine is overexposed, okay, and must be ICU patient where the trachea is everything. Right side you can see dark, but it's not a pneumothorax, it is overexposed field. And cardiac shadow should be here, it is shifted there. The left heart border you can see, descending aorta you can't see, hemidiaphragm you can't see. So there is opacity behind the heart. And you can see the left main bronchus coming up to this level. So this patient, the upper lobe is intact, and this is due to collapsed lower lobe behind the heart. So collapsed lower lobe is here behind the heart, and the heart is shifted there because of the volume impairment. The upper lobe is on. I will show you the typical pattern of left lower lobe. I have X-ray there, and this is dilated the emphysema at right side. So it's an ICU patient, then you have to do bronchoscopy and look here whether there are thick pus or something obstructing there. So when you clear this one, then this gets expanded again. Right. Then the different lobes can collapse in different ways. Right. So this is, when you see now this X-ray, well centered, but there is haziness here. Right? Haziness here, but you can't see the left heart border. And descending aorta is nicely seen here. Right? So this is what happens when there is left upper lobe collapse. So when there is obstruction to the left upper lobe, it will collapse. And oblique fissure is here. The when left upper lobe collapses, it collapses like this way. Collapse lobe will come and stay here. Okay, left upper lobe collapse this way. So because of that, EA film, you can see air behind the collapse left upper lobe. That is hyperinflated left lower lobe. Okay, so this is hyperinflated left lower lobe. This is collapsed upper lobe. So this one, sometimes this apical segment can come between the collapsed lobe and the aortic matrix. So it is called sign of Siche. So you can see a crescent of normal lung tissue there. Right? So this is collapsed left upper lobe. This is called whale sign. It's like a whale. Whale sign. Right? Then what happens to the left lower lobe? When it collapses like this, right, and moves behind the heart. Okay, when left lower lobe collapses, it goes like this. I'll show you some examples. So if you see a haziness left side, think of left upper lobe, right? So here, digital film is well centered, but the trachea has gone this way. You can't see the right hemidiaphragm, you can't see the right heart border. And this must be the transverse fissure and dilated right upper lobe. So this is actually suggestive of collapsed right middle and lower lobes, both. So when there is a truncus intermediate lesion, that can happen. So he had a truncus intermediate lesion. This one, you can see the heart border, you can see the hemidiaphragm, but this is the transverse fissure moving now. Again collapsing, not totally collapse, but collapsing lower and possibly plus or minus middle. Right. There are other features. You can see the deviation of trachea. You can see the elevation of right hemidiaphragm. You can see the volume impairment. Right. So all suggestive of collapse. There is volume impairment. Now here also you can see the volume impairment. Deviation of the heart shadow to this way. Trachea. There is underlying lung collapse. Right. Lower and middle. But you can't see the right heart border here, and there is opacity here. And if you see haziness here, with if you can't demonstrate right heart border, there is something wrong in the middle lobe. So you do a lateral and see. So you can see the oblique fissure here and some opacity in the middle lobe. Possibly segmental collapse, right? And then This is the trachea. I told you next to the trachea, very few millimeters of soft tissue should be there. So there is a paratracheal opacity suggesting lymph nodes, right? So this is what happens in right upper lobe collapse. So this is a mass lesion causing right upper lobe collapse. And this is the transverse fissure. It should be 1, 2, 3, 4, 5, 6. It should be here, right? So because the right upper lobe is collapsing, this is hypoinflated middle and the lower lobe. So this is a collapsed right upper lobe. Okay. And in these patients, now we, as a habit, we look at inside the trachea also. Sometimes when you see inside trachea, you can see the mass inside the trachea, right? So this is again the very poor quality X-ray, underexposed, you can't see anything. There is an elevated diaphragm, volume impairment, and again right upper lobe collapse is there. And there are some post-TB X-rays, right? TB patients, when they heal, they get a lot of fibrosis, right? So these are like that. It's all post-TB ones. So what happens if TB affects the upper lobe? So these are all fibrous pleural thickening, and when there is a fibrosis, all these fibrosis start contracting, right? As a result, these vessels get, dragged up. So this is a normal position, should be somewhere here, so it's going up. So it's a fibrous left upper lobe, right? And maybe upper division, right? So these are all cavities, and this is a pleural thickening here, and this is a cavity with intracavitary body. So you have to think of mycetoma. So patients with TB, when they get, when they cure, later on they can come with hemoptysis, and you have to do X-ray and see whether they have mycetoma in addition to reactivation, right? Mycetoma and malignant formations. Nice X-ray that you won't see. This patient is referred to as glaucoma, suspecting insisted effusion, right? So this opacity here, right? I told you always look for descending aorta. So I can't see the descending aorta here. And if you look at the aortic arch here, it's a very big aorta. And if you take the history, this patient has come with interscapular pain, severe interscapular pain. So that is enough for you to suspect dissecting aortic aneurysm. So this is a patient with dissecting aorta. If you take the history, few words, that is enough. Then you look for dissecting aneurysm here. So this is a very big aorta, and from here it is going like this. So bulging, leaking aortic aneurysm. So this is a leaking aortic aneurysm here. So in its CT it was leaking and bulging, dissecting aortic aneurysm. So history is very important. Another cavitating lesion, but I'm keeping just to show you some changes there. So it's a lesion with some fluid levels there, right? And you can see the left costophrenic angle, but it is blunting here. So always think of pleural thickening or pleural effusion there. You can do ultrasound and see, or you can do a lateral decubitus and see whether this is moving, right? So nice lateral X-ray, that is why I am keeping. So this is the right side, the right lateral, and this must be the right, this must be the left here. So starting from left, the left hemidiaphragm, anterior one third you can't see, cardiac shadow, and this must be the right. Going like this, it is the oblique fissure, and then right side next to the posteriorly you see this lesion, like this. And this hemidiaphragm you can go up to this level, but this part you can't demonstrate. That is because there is some fluid in the posterior costophrenic angle, right? These are all TB patients with emphysematous lower zones with fibrous upper lobe, right? And these vessels should be here. It has gone up to this level, and this one should be here. It is also going up. And this is the trachea, see the contour of the trachea. And all these happens because of TB causing fibrosis and fibrous tissue contraction. And heart vein elongation is here. And this area has become emphysematous. It's a poor quality X-ray. And you can see volume impairment right side. And you can't see the vessels here. And there's a big mass in the trachea, in the hilum. And so this lesion is in the hilum. Here you can see the vessels merging with the hilum, right? So this one is this mass is there. This hilum. Right. Again, post-TB patient, but lot of things you can see. So left side is, now you can't see the cardiac shadow here, it is shifted there. You can't see the hemidiaphragm, you can see the descending aorta. So everything whitish with a dark area suggesting cavity. So it's a fibrosed left lung with a cavity, right? And the trachea, because everything collapsed. So collapse could be due to various things. Collapse could be due to bronchial obstruction. Collapse could be due to external pressure, like in pneumothorax and pleural effusion, and collapse could be due to fibrosis also. So this is a fibrosis, left lung fibrosis with cavitation, and heart everything shifted there. And this is hyperinflated right lung with some fibrosis in the right lung, right? So when one is collapsing, the other one gets compensatory emphysema. This one again TB, right? You can see the right hilum is going up, fibrosis, and this whitish area, that is pleural calcification, and this area may be pleural thickening, right? So these are all TB patients. See the trachea. All these things are suggestive of fibrosis. Right. This one just remember, right? This patient came with this stage. If you see this patient, this kind of X-ray, right? What is the diagnosis? Came with this area. So this is the trachea, and it is behind the trachea. What is the structure behind the trachea? Causing this disease. So this is achalasia cardia with some food materials, dilated esophagus. And this is a poor quality X-ray, but I'm keeping this one of our COPD patient who came with pulmonary edema. This is a big one, a bilateral pleural effusion, perihilar pain, some fluid there, right? Some people get upward diversion. It's a poor quality X-ray. It's not a good example for pulmonary edema, right? The patient is fine. This one transferred from the mother. Now we can't see the cardiac borders, perihilar, reticulonodular opacities are there, right? When you see this, think of pulmonary edema, think of atypical infections like pneumocystis, right? And the other thing is, you have to always think of lymphangitis carcinomatosis, so lymphatic spread of the malignancies. You have to examine and see. So there are a lot of lymph node, FNAC showing adenocarcinoma. So it's a lymphangitis carcinomatosis, right? But you have to think of pulmonary edema, atypical infection, everything, right? This is a young patient who came with the recurrent chest infection, 13-year-old boy with recurrent infection. From the time of birth, he was having this infection, right? Here you can't see the right heart border, it is shifted there, and it is emphysematous right lung, even coming up to this level, and this lung is darker than the right, a little bit rotated, and less vasculature here, right? And what has happened is there is congenital collapse of the left lower lobe. So this is the collapse lobe which is there behind the heart, because I can't see the descending aorta. Next to that there is collapse lower lobe. It's not a typical collapse, but this is a conjecture thing. The P suspected there. So in the CT showed everything. the patient who has exposure to silica. So they get what is called silicosis. So this is a reticular nodular opacity due to silicosis, and they get what is called X-cell calcification. And TB is common in patients with silicosis. So this patient actually came to us with TB. So this area suggesting cavity and right couple of changes and to TB. So he came with pulmonary TB. So background there is changes of silicosis. Okay. These are spot cases for yours, right? Sometimes you might get this. What is the diagnosis there? So that is why I am keeping these X-rays. What is the diagnosis? Huh? Oh, because you see rounded lesion there here also. This is neurofibromatosis, right? Neurofibromatosis patient can present with lung fibrosis. So it's pleural thickening, basal opacity suggesting lung fibrosis. Poor quality X-ray anyway. So thinly built patient, right? Everywhere you can see these peduncle-related lesions everywhere. Sometimes on X-ray you will see something like this. Always palpate here and see that lesion may not be there in the chest, maybe outside the chest, right? So I think is you can do a lateral and see. Otherwise you just examine and see whether this lesion is outside the chest before going and doing this CT and all, right? Because if the lesion is suspicious like pedunculated here, you examine the patient and see. Right, these two X-rays I am keeping to teach you something else, right? This is the patient with TB, and all these changes are TB inside, right? The pleural thickening of pleural fluid, and these patches, all these due to sputum positive PTB. But that is not that what I want you to see. And this patient is a diagnosis of multiple myeloma. Okay, a lot of fluid fractures and all. So you can see multiple fluid fractures. This is a diagnosis of multiple myeloma. So multiple myeloma patients can have severe osteoporosis. So this is severe osteoporosis, and even the soft tissues and the bones look similar. So this is severe osteoporosis. That also you have to detect when you see X-rays, right? But in this case, you can see all these bones are whitish. This is bone sclerosis, right? This patient has bone sclerosis in addition to TB. This patient has severe osteoporosis due to multiple myeloma, right? So bone sclerosis like this, you can get with disseminated CA prostate, right? Chronic renal failure, and then the other one is fluorosis in Anuradhapura area. Okay. So when you see X-rays, in addition to the lesions, you have to concentrate on bones also, appearance of bones, right? This is just to show you encysted fluid with transverse fissure fluid, oblique fissure fluid. So this should be right side. So right side encysted fluid, although they have done a left lateral. So right is this, right? So it's the right sided encysted fluid here with fluid in the oblique, and so you can nicely see the fluid in the fissure. So that's why I'm keeping here. And this may be some tablets. This is a patient with CA esophagus who has undergone. So you can get these things in your spots. This is a stent, esophageal stent, and coming with a rounded lesion, possibly secondary stent. So you have to detect this esophageal stent coming with the secondary deposit there. This is how you describe. So this is the typical appearance of left lower lobe collapse, right? So lower lobe, I told you it collapses and goes behind the heart, right? So when the lower lobe collapses, you get hyperinflated left upper lobe. When the left upper lobe collapses, you get hyperinflation of the left lower lobe. So this is a collapsed left lobe. The asthmatic patient who came with difficulty in breathing, and this is the X-ray. So asthmatic patients, they can have mucus plugs obstructing bronchi. So this. So we did bronchoscopy, everything, and this disappears after that. Okay. So this is called sail sign. So behind the heart you can get triangular opacity. So I can't see the descending aorta. This part of the hemidiaphragm I can't see, because above that there is collapse lower lobe. So everything collapsed. And this area, this is the hyperinflated left upper lobe. So you get darkness here compared to right side, because everything vessels get displaced like this, right? So you get increased darkness here. So it's a typical left lower lobe collapse. Just to show you one patient who came recently, right? This is the left side. You can see a left lung abscess, and we have put a pigtail catheter there, right? And it got better. This is the right hemidiaphragm, you can see nicely. Left hemidiaphragm you can't see, because above that the abscess is there. This part of the left diaphragm you can't see because of the abscess. This part you can't see because of the cardiac shadow, right? But you can see nicely the right hemidiaphragm, the left actually. So this is the left, this is the right, and we have inserted the pigtail catheter there. And post-stage weight. So remember this also. So this looks like a pleural effusion, but it is not a pleural effusion. Within that you can see some opacities suggesting bowels. So this is a diaphragmatic hernia with bowels in mouth, and everything shifted here, cardiac shadow, right? So it's a diaphragmatic hernia, maybe having some calcific calculus in the left kidney also. This one recently came with bilateral patchy opacities, ill-defined patchy opacities. It defends a malignancy, but we have to consider other possibilities: vasculitis, bronchopneumonia, TB, everything we have to consider. But this is very suggestive of malignancy, right? Right. So I told you, if you can't see the next heart, the heart border right side, you have to suspect something in the middle lobe. So this is in the middle lobe. So partially collapsed middle lobe. Diaphragm and all you can nicely demonstrate there. This is collapse upper lobe. So when the upper lobe collapses, right, everything shifts this way. So, and this is the middle lobe you can see, because the cardiac heart you can see, and the lower lobe and the middle lobe is intact, and this is trachea. So this is collapse upper lobe. This is the lateral lymphatic collapse upper lobe. That's two more. Right. This one I'm just keeping here because this patient came to private sector during this COVID period, and it's a 40-year-old male patient with difficulty in breathing, right? And they have done an X-ray here and sent back. The operation was okay, X-ray looks normal, they have sent back, but came to private sector. And I did a repeat X-ray, but hardly any changes. But if you see clearly, you can see some increased opacities here. This. And I checked because the patient was dyspneic, I checked the saturation was 80 or something. The young patient, previously healthy, and saturation is very low, right? So if you see a normal looking X-ray and the patient is ill and hypoxic, there are things that you have to think of. One is these acute interstitial lung diseases like acute hypersensitivity pneumonitis. They can have a normal looking X-ray, but the patient is hypoxic. If you do a HRCT, you will see a lot of brown glass. Other one is AIP, acute interstitial pneumonia. Acute interstitial pneumonia. Other one is the PCP pneumonia or BJP pneumonia. Pneumocystis carinii pneumonia. So this patient I suspected pneumocystis carinii, and HIV became positive, and we treated with 4 times and steroids, and he got better. Now on antiretroviral therapy. The other possibility that you have to think is the pulmonary embolism. The X-ray will be normal looking, the patient is hypoxic, dyspneic, and the X-ray looks normal, but they are hypoxic. So normal looking X-ray with hypoxia, think of these acute interstitial pneumonia and the pneumocystis carinii and the pulmonary embolism, right? And also biliary TB, sometimes very early stage the X-ray may look normal, but later on they will develop miliary shadows 2-3 days later, right? And I'm just keeping for you to see a lot of changes are there. Now if you look this X-ray, you might think that it will be difficult to read this. No, it is easy to read if you know the normal X-ray, right? This patient came with fever and right-sided chest pain, right? And there is past history of TB. So these are all TB changes. Then you can see overlap scapulae, and this patient is getting oxygen. So it's an ill patient. Scapulae is overlapped, so that means we have taken an AP film. Then you can see the skin here. No soft tissues there. So it's a severely wasted patient. No soft tissues, right? Then these are all TB, and cardiac shadow is shifted here. Vessels gone down. That is because of the all TB, with some fibrous left upper division. And then right side you have some inflammatory shadows, and this is, you can see whole spine. So this is overexposed film also, right? And this area some pneumonic changes are there. And in addition to that, there is a nice some other change. Can you all detect this? Some people detect this. So I told you to see X-rays, you go to look at the trachea, then bronchi, then lung tissues, then abdomen, then ribs. Everything you have to look at. Anything wrong there? Sorry? So this is a AP film, lying down, wasted patient. Anything obvious there? Yeah. This side one rib is missing, right? If you look at the ribs, 1, 2, 3, 4th rib is here, but this part of the 4th rib is missing, and this part of the 4th rib is there. So this is a little lesion in the rib. So this patient has a malignancy in addition. So he has come with wasting malignancy, past TB, and this is some secondary pneumonia. Right? So this is the importance of going according to some order. Then you will catch. Right? Although this difficult looking X-ray, but if you know the normal chest appearance on a chest X-ray, you can detect. But you have to go in an order. So that is the message that I want to give with this X-ray. And then this patient came to me this Monday. But you saw this, you saw this. What is this? Can you see this? It's 22nd May, Monday. That is it. What about the lungs? All right, right? And your cardiac shadow should be less than 50% of the width of the neck. So this is very big heart. Now look at the heart. Now heart is 50% is the right atrium, the ascending is the descending. This is the left ventricle, right? And these are pulmonary arteries. Here, what has happened here is, this is the left ventricle, but there is another bulge here. This is the dilated atrial appendage, right? And then you have a double shadow here, across the enlarged heart with a double shadow. This is a double atrial shadow. There is the right atrium, this is the left atrium, which is dilated. Left atrium is dilated. So when it is dilated, now this is the carina, right? The normal appearance. This carina gets wide. So below that, dilated left atrium is there. So this is what happens when there is severe mitral stenosis, right? When there is severe mitral stenosis, left atrium gets hypertrophied and dilated, trying to push blood into the left ventricle, and left ventricle is all right actually here. So this is a dilated left atrium, and then you get congestive cardiac failure, pulmonary hypertension, upward diversion, pulmonary edema, and the right side failure also, right ventricular enlargement and right atrial enlargement also later on. So he has everything. So this is my turn. So I didn't talk about this cardiac appearances. So when you do cardiology appointment, learn about different patterns in the heart, right? What happens in hypertension? You get globular dilated left ventricle, right? In phallostetrology, you get something like boot-shaped heart, right? In coarctation aorta, you get rib erosion in fourth and fifth, like something on the left side, right? And then ASD, you can see the changes of ASD. Mitral stain, this is the typical pattern you see, right? Cardiomegaly, dilated left atrium, double atrial shadow, and dilated left atrial appendage. So learn about cardiac pattern later. So when you read X-rays, just see the identification, then rotation, inspiration, and the exposure check, right? And then go according to some order and look what has happened to the normal X-ray, right? You know the normal X-ray, you know the normal anatomy there, and just see what has happened to the normal pattern. Then you will be able to describe various lesions, various differences from the normal pattern, and use the terms that is being used by your radiologist, right? So this is how I read chest X-rays, and